First of all, thank you very much for the invitation to the organizing committee to speak about the topic that will affect our treatments and our patients in the future very much. So these are the disclosures, and this is why our treatment fails. And how do we treat that? So this is a genomic landscape of a single cell line. And what you can see here is on the outer layer, there is the chromosomes, and then you can see all the methylation changes, overexpression, underexpression of genes, mutations, and genomic aberrations. So we should not be shocked by such a picture and that all the information that's in there, because even basic scientists who are doing this every day are overwhelmed by this information. And actually at the moment we don't know how to put all this together. But I would like to come back to scratch a little bit, and let's look how prostate cancer is diagnosed nowadays, and how is the outcome, and how has this changed over the last decades. So we all know that we have more than 400,000 newly diagnosed cases within Europe every year. And there are 90,000 deaths attributed to the disease every year. And if we are looking to these death rates, then we can see that this has not been changed that much over time. If you compare the American data, age and population adjusted, they are almost the same number of deaths we had in the 50s. And these data clearly show the difficulty we have in prostate cancer. It's on the one side we have an overdetection of prostate cancer, and that it's clearly still combined to a huge amount of overtreatment. And on the other hand, we have those patients who are dying from the disease. And in the population setting, we have not changed that much in these patients. So there are two key points we have to solve in prostate cancer, and it's focusing on one point. We have to identify those patients who are at highest risk to die of the disease. That's first. And second, we have to improve the survival of these patients. And I will try to give you a little bit of information how we could do this. So why is next-gen sequencing helpful in this? It's because we have a central dogma in molecular biology. And that's from James Watson. You know him all. He got the Nobel Prize for discovering the structure of the DNA. And you all know that DNA is transcribed into RNA and then translated into proteins. And that's what drives our cells. So once we have the genomic DNA sequence of a cancer patient, we have all the information there is. That's the reason why so much energy was put into discovering and analyzing the DNA sequence. And it was mentioned yesterday in this excellent presentation from Professor Clarke. Frederick Sanger received 2 Nobel Prizes for 2 really outstanding research points. And one is the sequencing, the Sanger sequencing. But and probably Noel, you remember this as well, when I started my career, I was working in a molecular biology lab, and we were sitting in front of exactly that, what you're seeing here. So analyzing DNA sequencing from a jail, well, it was time consuming. It took days, weeks, months, and even years to analyze all this information. So lots of energy has put into improving this. And this is a machine, one of the machines we have nowadays to do next-gen sequencing. And with such a machine, you can analyze the entire genome of one patient within 1 day. And it's not only the time that has improved. The beginning of this century, the costs for a genome analysis of one patient was around $100,000, and it dropped. It's below now, below 5,000. So we have lots of improvement in this, and of course the availability of these analyses is increasing. So what can we do with next generation sequencing? It's a word we are not so much aware with the details. What can we analyze? So here you can see next gen sequencing, and what we can analyze is somatic changes. And you can analyze in different ways. You can do a whole genome sequencing everything, huge data, bunch of data. To analyze this, extremely difficult, still high costs in this. But you can also select only the exome and do an exome sequencing, only the coding regions. Or you can go for RNA sequencing, where you sequence only the RNA that you find in the cell. And you can select this further for a gene panel or single genes. And what you find is point mutations. You can find structural changes, you can find fusion genes, and all this together you can use to classify patients, to classify cancers, to develop biomarkers, to identify molecular targets, and then finally to personalize treatment with potentially prostate cancer-specific biomarkers. You can combine this with genome-wide association studies and getting a more comprehensive picture, making it even more complex. So that's what many people are working worldwide at the moment. Well, let's go back to prostate cancer. So we have differences in prostate cancer when we diagnose it, and also over the course of the disease, over a lifetime of a patient. So we have those patients with strictly localized cancer. We don't want to treat these patients really in many cases. We have heard this yesterday. Then we have the locally advanced, the high-risk population, maybe with positive nodes, maybe with oligometastatic disease. And then we have the metastatic setting, hormone sensitive and hormone resistant. And the questions we have in these three populations are entirely different. So if we're looking for the low and intermediate risk population, then what we have learned, and it was mentioned yesterday, that's data from the PROTECT trial, that the 10-year cancer-specific mortality is rather low, even in untreated patients. It's below 5%. So the challenges we have in this population is to reduce overtreatment and side effects of localized treatment. And then we have the high-risk population. That's 15 to 35% of all patients that are newly diagnosed, depending on the country you're living in. But the risk of biochemical recurrence after radiotherapy, plus hormones, or surgery is up to 70%, depending on the definition you use. And around 30 to 40% of these patients will get metastasis over time, and then finally are at risk to die from the disease. And it's important to note that 60% of all the deaths we have in prostate cancer were initially diagnosed as high-risk disease. So that's an important population. And the challenges are to increase overall survival, but it's a heterogeneous population. We have also to reduce the side effects of localized treatment. So what have we as biomarkers at the moment? So to diagnose or to schedule patients for biopsy, we have the PCA3 test. You're all aware of this. A couple of years ago, it was very popular. It's an mRNA, non-coding, that is associated with cancer detection. And in meta-analysis, it's shown that you can identify patients that may benefit from a second biopsy to identify cancer, and it was approved by FDA. My personal view on this is that MRI took this over. So from my point of view, this has no relevance anymore. And MRI is probably much better. So what do we have at the moment with diagnostic and prognostic tests? So we have biomarkers to predict adverse pathology. You have seen this yesterday with a hazard ratio of 4. We have Prolaris. That's a cell cycle progression setting. We have Decipher. That's a test to predict outcome after surgery. In the high-risk population, you can identify these patients better that may have recurrence. And then what you finally can give is for different populations, you can schedule different endpoints, and then you can make a clinical decision point. But none of these tests has ever been prospectively validated, and we don't know if these tests are really worth scheduling patient for treatment. I will jump over this a little bit and over this as well, because I have a little bit of over-exceeding the time, I guess. So let's come to the deadly disease, the metastatic prostate cancer, because that's an important point and it will take some time to explain this. So the challenges we have there is to overcome hormone resistance. We have to develop new, more effective treatments, and we have finally to increase overall survival in these populations. And this is a hot topic, next generation sequencing in these patients, but what are we doing with the information we get from this sequencing? So here you can see a little bit, we can identify somatic mutations, but there you have some driver mutations that drive the biology of the tumor, and we have some passenger mutations. And then you can focus these up more and more, and finally identify recurrent combinations of mutations that drive the cancer, and then you have to show that these driver mutations have experimental function. So they should really drive the cancer, and you should test this in a model, and then you can go further into patients. So this has been shown yesterday as well. That's one of the, probably in prostate cancer, very important publications at the moment. 690 men that all had metastatic prostate cancer, and they were analyzed with multiplex DNA sequencing of 20 DNA repair genes. So, and what they found is that 12% of the patients with metastatic prostate cancer had mutations in DNA damage repair genes. It's quite a lot. And one of the most frequent is the BRCA2, which was found in about 40% of the patients. So what we know from ovarian cancer is that patients with ovarian cancer has a worse outcome. So survival is that there is no 3 years survival is, or was in the past, almost zero if you are metastatic. But this has changed because they identified patients with a BRCA2 mutation, and they were treated either with platinum-based chemotherapy or with specific drugs you've heard about yesterday, where you can influence this mechanism, and then the survival is better. So the question is, does that work also in prostate cancer? And olaparib is such a so-called PARP inhibitor. So it's a polymerase inhibitor. And Professor Clarke showed you yesterday that you have the 2 alleles. We have always 2 copies of each gene. And if only one is altered, then the second one is still making the problem. But if you affect the second one and you knock it out functionally, you have a lethal situation. So it's a synthetic lethal way you are driving, and then the cell dies. So what you can see here, that's a study, a phase 2 study, 50 patients. They were all castration-resistant metastatic prostate cancer. And what is important is that 14 out of the 16 men with DNA repair defects responded to olaparib. That's quite interesting. So we can identify for the first time, except for the hormonal treatment that it's effective in every patient, we have the first time a way to identify a patient that may benefit from an additional treatment. And here you can see on the left side, that's the radiologic progression-free survival. The blue line, the patients with the mutation, the red line without, and it's the same for the overall survival, for the progression-free survival. So the patients benefit from this. There are sub-analyses of several surrogate endpoints. I will not go into details for this. So this is first time we have a molecular substratification based on next-gen sequencing guiding treatment in prostate cancer. And, well, that's the conclusion in patients whose prostate cancer were no longer responding to standard treatment and had the defect in DNA repair genes. Treatment with olaparib led to high response rates. But not only this, I already mentioned that patients with ovarian cancer, they respond also to cisplatin-based therapy. So this is a case series published in European Urology. And that's quite interesting. It's 3 patients, and what you can see here is the PSA level of these patients. And in the first one, here, at this time point, it was carboplatin induced therapy, and then you can see that over a 1-year period, the patient benefited from this treatment, and he was taken off, got recurrent, and again, treatment was initiated with a quite excellent effect. And here, that's a second patient in the middle. You can see it's not followed up that long, but there is a decline in PSA. So that's end-stage disease. This patient had ABI, ENSA, and docetaxel before. And then below here, maybe that's the most interesting case with a long-term response over several years with a platinum-based chemotherapy combined with docetaxel. So that's probably what we will see in the future. And we will have to test this. But how do we use this in our daily clinical work? We, as urologists, we have a tumor board. And this is a publication where molecular substratification and the molecular tumor board guides treatment and tries to implement and use all this information that we can get out from the molecular substratification and from the genomic tests we have. But what we first need is prospective clinical trials showing a benefit for the patient. And there are 2 initiatives worldwide doing this. This one is it's molecular-driven cancer treatment. It's the MATCH trial in the US. It's a fantastic system, I personally feel, although it's difficult to include patients because we have a problem of downstream trials. So the patients are sequenced, and then according to their, molecular subtype of the cancer, they are scheduled for certain treatment. And a similar approach has been developed by ourselves together with EORTC, the SPECTA-PROS platform. It's prostate cancer. So the MATCH trial is not prostate cancer. It includes imaging because imaging is much quicker. It's much more expanding in the moment, but it has also the part of a molecular substratification. And we have a screening at baseline, and then you can put the patient into downstream trials at a certain time point of their disease. So that's what we have to do first. So in conclusion, you have seen that next generation sequencing provides us with a better understanding of the molecular diversity of prostate cancer. It will help us to individualize prostate cancer treatment in the near future. This will not take decades. Those of you who are 60, they may be not affected by this, but all of the rest of us, that's what we have to do in the future. But we need to test this, and we need a new platform-based clinical trial strategy away from the classical way, phase 1, 2, 3 trials, to establish this, to generate data, and to get evidence that this treatment is really effective. Thank you very much.